Hey guys, so in this video lecture, we're going to be talking about infections specifically of the respiratory tract. So some of this might already be a little bit of review, especially whenever we get into like the flu, about the angenic shift and drift. But it's definitely very important for you to be able to apply that knowledge, especially with the flu, because it is very, very common and you'll probably see it a lot as nurses. So let's go ahead and get started. So are all infection of the respiratory tract, are they the same? And no, they are not the same. No one infection is going to be ever the same. Just like think about if you've ever had a cold before, your colds vary very differently. Sometimes you have a higher fever, sometimes you have more chills the next time you get a cold. So they're never the same. And the reason why is because it will vary whether or not what part of the respiratory tract is actually infected, such as the upper or the lower part of it. So the upper part of the respiratory tract is your actual airways, your nasal cavity, your oral cavity, your pharynx, and your larynx. So if you think about it like a sinus infection. And then the other structures that are also included in the upper respiratory tract is like your tonsils, your sinuses, your epiglottis, your inner ear. Those are all considered part of the upper respiratory tract. And then the lower respiratory tract is like your actual lungs and like your areoles and everything. So with that, let's go ahead and look at some images. Sorry, brain fart. Some images of the upper respiratory tract. So we have, this is the entire upper respiratory tract, and then later on we'll actually see an ear canal, but we'll do that later. So like you have all your sinuses and everything, you have your nasopharynx, you have your, like I said, your epiglottis. So all of that, if it's ever inflamed, then what part of the upper respiratory tract is inflamed will help you in classifying your infection. So such as like on the previous slide, like if you have inflammation of like the mucous membranes within the throat, then that is pharyngitis. Or if it's inflammation of just your larynx, then it's laryngitis, and so on and so forth. Okay? So now the lower respiratory tract, like I said, is like the trachea, the bronchi, and the areoles. I think that's how you say it. Or alveoles, I don't know. But ravioli, we'll say ravioli. So if you ever get an infection of your bronchi or your bronchi, it's bronchitis. So some of y'all actually may have actually experienced this, or if not, maybe like one of your parents have, since they are older. It's a little bit more common in the older population. And then also, if it progresses, like if your bronchitis progresses, then a lot of times there's a complication called pneumonia. So this is where your pulmonary areoles become involved. So that is the part of the lungs where gas exchange occurs. Okay? And then also, a lot of times with these kind of infections, like you have a lot of mucus and everything. So mucus is formed whenever something called mucin is secreted by goblet cells. And then that is, goblet cells, they generally reside within the epithelium of your lungs, and then a lot of times it'll combine with water. So whenever mucin and water come together, you get mucus production. Okay, and then we've also talked about cilia within our lungs whenever we talked about the normal microbiota. So that cilia, what it does is that it's constantly moving. And then what it does is that it's moving the mucus that's trapped. And then as it moves the mucus, it's moving it out of your system through your mouth and then your nasal cavities. So that is why sometimes you'll get like excessive cough, because your cilia is trying to be like, hey, I need this crud out. And that's why sometimes, like whenever you blow your nose, sometimes it's like extra snotty. And then also whenever you cough, you get that yucky, the mucus, the jello stuff out of your whenever you cough it up, because that is your lungs expelling the nasty. And a lot of times people who are like smokers or anything like that, they tend to it tends to be harder for them to clear it out, because there are there is damage to their lungs. So no smoking, guys. Smoking is bad for you. Okay, so with that, let's talk about the common cold. So the common cold is probably the most common of them all, virally, of the upper respiratory tract. So we are always around a cold virus. Now, there are many, many different subtypes of a cold. So, your body, the likelihood is that your body will always have to have some kind of initial innate immune response, and there might be a little bit of adaptive depending on assuming that the cold virus didn't you didn't get infected with a different cold virus you haven't seen before. But normally the average person may suffer like one or two colds throughout the year. But a lot of times children are the ones that actually suffer colds more so, and that's one because they're dirty and then also because of the fact that they don't have a robust immune system yet. So the common cold is called a rhinovirus. So this is um, the most diverse one that does cause the cold, and then it is predominant. Um, it is very, very predominant, primarily in children, but adults can get it as well as the elderly. And then a lot of times it can be combated, meaning that it can be in presence of other viruses such as like influenza. We'll talk about him a lot. Influenza, big player. But that's the most important one out of all of them. Or there's para-influenza, or there's corona virus. But the most important ones I want you to know, at least from this slide, is the rhinovirus, which is the most common cause of the cold, and then influenza as we go later on. So if you get a common cold, then a lot of times you get like sinus swelling. So that's inflammation of your sinuses. So like you'll feel like a lot of pressure, like in your nose. You may even feel some like in your throat, depending on if you're coughing a lot. But generally, it's the common cold is maintained essentially in your face region. It doesn't really disseminate into your lungs or anything. You don't really get a lot of mucus production when you have the cold. It's normally self-resolving. You don't need any medication. You're, for the most part, down for a week and you're good. You're good later. Okay. So the lower respiratory tract viral infections, there is one specifically, the RSV. So this one, it's got its name because of the fact that the cell has a lot of nuclei inside of one single cell. So it's multi-nucleated. This one is transmitted from person to person, kind of just like any other virus, like the flu, like the cold. This one, what it does is that the virus will come in contact with your mucous membranes, so such as like your eyes, your mouth, your nose, or through actually inhalation of droplets that somebody sneezed. So let's say your 3-year-old sneezed. He has this RSV virus inside those like little air droplets. Whenever you sneeze, the virus is inside of there, and then you inhale those viruses or you come in contact with them. So like let's say your child sneezed at the kitchen table and then you touch the kitchen table and then you touch your face. It can also go that way. So like I said, it's mainly in children. It is the most common cause of bronchitis and pneumonia. And normally by the age of 2, all children have probably been infected by it. So it's normally self-resolving. Sometimes you do need medication, like some supportive treatment. So maybe a child with spike of fever, so you'll give them some Tylenol. Or they have severe inflammation, so you'll also give them Tylenol to aid with that. A lot of times you don't need any antiviral treatment, you just do supportive care. So this is just a of a picture of the actual virus to show that it is multinucleated. So this is a new budding budding virus, I guess. So like this is the host cell, and then what it already traveled through, and then now it's budding off so it can go travel and infect other cells. But as you see, throughout the budding system, you do see these dark little spots. So that is the multi-nucleated. That's really it. I'm not really too concerned about you being able to identify that in a picture. Okay, so influenza. Influenza, we've kind of talked about him already before, but he's divided into 3 categories, so type A, B, and C. So how he's divided is dependent on their angenic determinants. So meaning that type A and type B, these guys, they both result in the quote-unquote flu, meaning the most presentation that you'll see in humans. Type A is probably the most common for most cases. So type A influenza, what it does is that it can infect various animals. It's primarily found in avian, but it can also cross species, just like it can cross into us. And type A is constantly changing. Whereas type B, this one is predominantly found only in humans. And this one will result in a minor illness. And then type C causes only minor disease. So none of these are actually really, nasty in general. But when they become nasty is whenever they mutate. And we'll talk about the angenic shift and drift in the next slide, I believe. But the normal pathogenesis of the flu virus is largely dependent on 3 different surface proteins that they have. And we talked about 2 of them already. We've talked about the HA and the NA. So HA, this is specifically a protein that they have on their surface that will bind to our surface of respiratory cells. Okay? And then NA, this is the one that actually allows it to leave our cell. So for example, let's say that the influenza virus was actually deficient in the NA protein. So if you didn't have the NA protein, that's actually really good for the host, because if the virus, in the case of influenza, if he's unable to leave the host cell, he cannot continue on infecting other cells. So that's actually really good. And then also, in the same case of the HA protein, so if there's no HA present, then there's no binding. So no binding, no infection. So that's good. Now the other one that we haven't talked about yet is the M2. So this one, what it'll do is that it will create pores inside an endosome. And with that, it allows for genetic material to gain access to the cytoplasm. But I'm more concerned about you knowing the HA and the NA. Okay? Okay, so why are some flu viruses more severe and cause harsher disease compared to others? So the whole reason that we talked about before is angenic shift and drifting. So for influenza specifically, so I'm going to be using influenza as the context. So because influenza can cross species, because it has a broad host range, so it can infect pigs, birds, humans, primates, it can infect a multitude of hosts, then that means that it can also infect the different types of cells. So whenever you have a flu virus that generally infects human or generally only infects pig, but then they come together because they can infect the same cell type, or multiple cell types, I should say, what will happen is that the flu genome, the sequences of its genome, it will uncoat and mix inside the cytoplasm whenever it's multiplying. And then with that, it rearranges, and then you get a whole new virus. And then this happens a lot of times, almost all the time actually, it happens a lot. But specifically, a lot of times it will form a new HA gene. So the fact that it can form a new HA gene, it can bind even more, because that HA gene is specifically for binding. And whenever that happens, whenever there's 2 flu viruses infect one cell and rearrange, that's called angenic shifting, which we've already talked about. So that is one of the main reasons as to why the flu virus is constantly always changing and very, very diverse. And then antigenic drifting, this is whenever there's just random mutation that happens over time, and that can also alter the HA structure as well. Okay, so I do have a video embedded in this PowerPoint. I'm not going to show it, but you're more than welcome to look at it for yourself. It is a Khan Academy video over antigenic shifting and drifting, and she does a very good visualization of showing the antigenic shift and drift. Okay, so that's enough about flu. Now let's talk about ear infections. So ODS media, this is an acute ear infection, or also known as AOM. So this is probably the most common diagnosed sickness in a child whenever they go to the pediatric office. So children are very, very prone to ear infections, and the reason why is because of their anatomy. And I'll show you a picture of the anatomy on the next slide. But majority of children, almost all children, will have at least one episode of an ear infection by the time they're 2 or 3. And like I said, it has to do with their anatomy. And then also what will increase their chances of getting it is if they are in a daycare setting, or also if their siblings have it. And then a lot of times they are caused by bacterial species. They're not really caused virally. But there are some cases where a ear infection can be caused virally, but it's not very common. But the 3 most frequent bacteria species that will cause it is Strep pneumoniae, is H. influenza, and Carhalius, I believe that's how you say it. So those are the 3 most common species. Virally, not so common. So anatomically wise, children get more ear infection. Has to do with this E-tube. So this E-tube, whenever you're a child, it doesn't have a very good angle. So it's only 10 degrees. So it's almost a flat line. So with that, that means that there's not a lot of drainage is happening. So your body's always trying to get rid of stuff, always trying to clear it out. But what happens is that the tube is smaller, and it's also almost completely horizontal. So it makes it very, very difficult to drain stuff. And with that, sometimes some of that drainage will sit there and fester. And whenever there's drainage there and then bacteria comes in contact with it, the bacteria will grow inside that drainage. And then that is where you'll get the infection. Whereas with adults, we normally don't get a lot of ear infections because of the fact that we are able to actually drain through our nose because the angle is increased. So whereas it's like 10 over here it's closer to 40, 45. But with children, sometimes if they have like chronic ear infections where it's just constantly ear infection, what you can do is actually have something called a temporary tube, or permanent, depending on how severe it is. A little tube that goes in and actually just kind of like opens up this cavity. And with that, the fact that the cavity is more open, drainage can actually go more freely out. That's one way of temporarily treating it. It kind of just depends. So like I said, they can be permanent or they can be temporary. So if they're temporary, a lot of times you'll get them removed at, I believe it's like around the grade school age, so around 7, you'll get them removed. Or you can have a permanent solution where they are, it's like a stent, like for your heart, it's that, and then it just stays there forever. So kind of like a permanent retainer, but for your ear. Okay, so definitely know why as to children are more prone compared to adults. Okay? Okie dokie. So now let's talk about bacterial sinus infections. So the same pathogens that cause the ear infections are also the same ones that infect the sinuses. So such as the strep, strep, and then H. influenzae, and then M. Carlahalus, sorry. So those are the same ones that cause sinus infections. So this one, a bacterial sinus infection, a lot of times will accompany a middle ear infection in children and then pneumonia in adults. So if you think about it, it's all linked together. your sinuses are very, very close to your ear canal. So it makes sense to the fact that sometimes if you have a sinus infection, you may even get an ear infection at the same time. And then a lot of us have probably experienced the sinus infection before. I'm actually just getting over one. Um, so that's whenever you have like the pressure behind your eyes, in your face, so like your cheekbones. You get a lot of discharge from your nose. And sometimes breathing can be a little hard because you're all swollen. And depending on how severe the bacterial sinus infection is, you may want to have antibiotics for treatment. But sometimes they can self-resolve just depending on the person. So patients who have a sore throat, it can be multiple things. So it can be their pharynx, it can be their tonsils, or it can be their larynx. So that is why whenever like your patient thinks that, or not thinks, says that they have a sore throat, you want to make sure that you're looking to see which part is actually inflamed. It may be one or it may be all. Just kind of depends. A lot of times, whenever your patient will complain of a sore throat, you want to do some differential diagnostics. So the reason why you want to do differential diagnostics is to determine if you have a viral or a bacterial pathogen that may be causing this. And then also a sore throat may not be because they actually have a viral or bacterial infection of their upper respiratory tract. So that's another reason why you want to do some differential diagnostics. Okie dokie. So let's talk about strep pharyngitis. So this is also known as strep throat. So a lot of us have probably been exposed to this. Some of us may even experienced it. But strep throat is highly contagious. So it is spread from person to person or indirect contact from a contaminated surface. So let's say, like I said, like somebody coughs whenever they're at the table, they don't properly cover their mouths or sanitize the area. And then the next person comes in, sits down, and then they're touching, they scratch their face. Then all of a sudden they have strep throat. Now the hallmarks of strep throat is very, very quick onset fever, a severe throat, tenderness, as well as enlarged cervical lymph nodes. So that is around your collarbone and maybe even a little bit further up your neck, depending on your anatomy. And then also your tonsils will be very, very exudated, meaning extremely swollen, very, very red. And then a lot of times whenever you have strep throat, you don't have a cough. So let's go ahead and look at pictures of strep throat. So so this is the classical hallmark of strep throat, so kind of like the strawberry throat. Now with children, sometimes if it is caused by certain species of strep, such as S. pyogenes, it does create that exotoxin that we've talked about before. And this is where you will actually get excessive rash on the trunk, and then even the strawberry tongue can also be present. But that is sometimes more prevalent in children as compared to adults. For the most part, adults, if we get strep throat, you'll get that cherry throat. Now with children, a lot of times they're more prone to getting the strawberry tongue as well as the rash. So this has to do because of that exotoxin being produced. So if S. pyogenes is producing that exotoxin, a lot of times you'll see these two clinical presentations. Okay, so keep that in mind. Now also, we have strep soliloquy, or I think that's how you pronounce it. So soliloquy has to do with a pathological condition that will result from a primary infection that already happened. So meaning, let's say I had strep throat and then it cleared and I'm good to go. And then all of a sudden something else happens. So that is a soliloquy, meaning that you'll have a condition that will happen after you've already cleared the primary infection. So this is very, very common with Streptococcus species. So what it does is that it's causing another immune response. So S. pyogenes, it has that M protein, remember, with the pilus factor that we talked about, I believe, like a lecture or two ago, that aids in attachment to host. So the fact that it has this M protein, or some strains, not all, have this M protein, what it does is that it can actually attach to similar cell surface proteins, such as on the human cardiac or kidney cells. So a lot of times the fact that Strep pyogenes has this M factor, rather than just attaching to our respiratory cells, it can also attach to cardiac and kidney cells. And with that, you can have two presentations. You can have rheumatic fever, which is the inflammation and soreness of your joints, your skin, and your heart. And sometimes it can even be of your nervous system. But generally, it's kept to your joints and your skin and heart. Now, if it attaches to your kidney cells, I'm not even going to attempt to say that because I think y'all will just get too much of a giggle from it. But with a kidney disease, then you will have a presentation of this. So just keep that in mind, where strep can also cause a clinical presentation later down the line, even after you're done having the first primary infection. Okay, so now let's talk about diphtheria. So this is normally caused by Corynebacterium diphtheriae. So it's mainly in developing, more prevalent in developing countries, or the underdeveloped part of the world. But whereas here we are immunized for the most part, and that's why for the majority of it, diphtheria has been eliminated, at least in the more developed parts of the world. But it does remain a threat in other countries because they don't have readily access to immunizations. But in the recent years, it has definitely made a comeback because of the whole anti-vax movement. But C. diphtheriae, it is a gram-positive rod. There are two major forms of it. There's the lysogenized or the non-lysogenized. So if it's lysogenized, then that means that it has this DTX gene. So normally if you have diphtheria, you get sore throat, you get cervical lymph node endopathy. You might have like a low-grade fever, and then you'll get a grayish membrane on the back of your throat, and I'll show you a picture of that. And then also infections of the skin are lesions that have not healed. So sometimes you'll get lesions over your skin as well if you have diphtheria. Now with diphtheria, there are some cardiac manifestations, and that is due to the toxin being produced, which is that DTX toxin. And it will cause shortness of breath, it can cause irregular heartbeats, and then also it can even cause cardiac dilation, so meaning your heart can get bigger, which is not good. We don't want our heart to be any bigger than what it needs to be. Now, if you have diphtheria, the treatment is antibiotics as well as an antitoxin in order to treat the disease. And then also a good preventative method is doing the vaccine, which is that DTaP series. So D stands for diphtheria, T is for tetanus, and then A is for pertussis. So it's a combination vaccine. But here are some pictures of diphtheria. So this is that gray membrane that I was talking about. It's kind of like gray-white that will form on the back of the throat, and that is a general hallmark of diphtheria. And then this is the lesion that may or may not occur. It depends on how progressed the infection is. So this is the skin lesion that is caused by diphtheria. Okay, so whooping cough. So this is also known as pertussis. So this is another disease that is primarily residing in developing countries, not so much here, at least stateside. But pertussis is very, very contagious. It's caused by a gram-negative Bordetella pertussis. So it's a gram-negative rod bacteria. So what will happen is that you'll come in contact with it. So after about 2 to 3 weeks being exposed to pertussis, what will happen is that you will have you'll go through 3 phases. So the first phase is the carhale, I think that's how you say it. So this is where you have indistinguishable presentation. So it'll look like just like a standard viral upper respiratory tract infection. But then after that, what will happen is that you'll try to treat it, but then treatment doesn't work because you think you're treating a viral infection where actually you need to be treating a bacterial infection. So with that, a lot of times it'll progress into the stage 2. So the second stage is where you have a constant cough, where you just have this very, very violent cough. And then also sometimes since just such a violent reoccurring cough, vomiting can also occur. And then with the cough, you have a very, very hard time making deep breaths. And that's actually how the disease got their name, because of how the cough sounds, and then also how one breathes when trying to take a deep breath. And then there's the third stage, which is the convalescence. So this is where the coughing will gradually disappear for after about 3-4 weeks. It'll completely disappear as the patient starts to recover. But whooping cough can be very, very deadly. So a lot of times, like new mothers or daycare workers, sometimes children, they're not old enough to have the vaccine. So they tell the healthcare workers like, hey, you need to make sure you have your pertussis vaccine in order to protect the unvaccinated that aren't unable to. And then also a lot of times mothers, they'll get the vaccine too, because for the most part, adults, we won't really get whooping cough or pertussis. It is possible though. It's not impossible, but it's just not as common. It's mainly in children. And there's also a video link right here, but I'm not going to show it, but I will probably show it in class. And then also you're more than welcome to look at it on your own time. It's just a news story of a child that had whooping cough. But don't worry, the happy ending, the child's okay. Okay, so also additional things about whooping cough. So with whooping cough, there is a tracheal cytotoxin that will adhere to the cell wall or cell membrane. And with that, it will actually start damaging our ciliated cells of our respiratory tract. So that's actually a picture of it right here. So this is in a rabbit model, I believe, but they're very, very closely related to us. So what will happen is that your cilia will be trying to clear it, but then it has this cytotoxin that allows it to adhere and actually start like damaging all these ciliated cells. So the pertussis toxin, as it progresses, it can enter the bloodstream and actually even cause disease within your systematic part. So definitely do not want to get pertussis because it can be very, very nasty, especially like in children. But in order to prevent it, you get the vaccine. So let's get the vaccine, guys. And most of us probably already have it. Okie dokie. So with that, let's talk about bronchitis. So bronchitis is the inflammation of the bronchi. So this is usually acute and it's self-limiting, so meaning that sometimes you don't even need to have treatment, it'll just self-resolve. It can be caused virally or bacterially, and there's a lot of different presentations of bronchitis. But generally speaking, you'll have a productive cough, and that's usually actually the only symptom. Like you won't have a fever, you won't have chills or anything like that. You'll just have a very, very strong productive cough. So sometimes you may even have some mucus, kind of depends, but it won't be excessive mucus. But generally speaking, bronchitis is normally caused by a virus, but there are some bacteria that can cause it. And then a lot of times, if you do have bronchitis, it can turn into pneumonia. And if it does turn into pneumonia, a lot of times it is caused by mycoplasma or Bordetella species. And then with that, you have acute bronchitis on top of pneumonia. That's if it's caused bacterially. Now, community acquired pneumonia, so this is where it's acquired outside of a healthcare facility, meaning you got it just being out and about, not from a hospital. So, pneumonias, they're often classified as typical or atypical. So, atypical, this is where pneumonia will affect multiple organ systems. So, usually, what will happen is that you'll have a normal white blood cell count, and then what will happen is that symptoms will gradually appear, but they'll mimic a upper respiratory tract infection. So that's why sometimes it's it may be misdiagnosed at first. And the general cause of atypical pneumonia is M. pneumoniae, also Legionella, and then Chlamydia phyla or phyla. But if you have typical pneumonia, this is generally caused by strep pneumoniae. And I believe I have another slide on it. Yes, so for typical pneumonia, we have strep pneumonia. So this accounts for a good chunk of the community-acquired pneumonia. So this is normally among the elders, smokers, as well as immunocompromised, such as diabetics or severe alcoholics. So there are multiple serotypes of S. pneumoniae, but it will always colonize within the airway. So just because we have different serotypes doesn't mean that it'll colonize outside of airways. So this will only colonize within the airways, and then also a lot of times the population, if you do have it, you will also I lost my train of thought. Okay, just scratch that. So, like I said, it will colonize within the airway, but S. pneumoniae, it can actually just be a normal commensal within our nose and our throats, because we are a normal reservoir for it, meaning that it generally just lives on us and it's fine. So it's a normal commensal. There is a vaccine against it. So it's not 100%, of course, just like any vaccine, but a lot of times you will encourage the elderly to get this vaccine in order to prevent S. pneumoniae, because pneumonia is very, very hard on the elderly patient. It's very, very hard on them. So there is a vaccine against it. So that's good. Okie dokie. So just a few more slides, guys, and then we are done. So another thing on atypical pneumonia, so it's, like I said, it is commonly caused by M. pneumoniae. So what makes him very, very different is the fact that he actually lacks a rigid cell wall. So he's normally like in a filamentous form, so he's a little bit more fluid. And a lot of times symptoms, your patient will come up with headache, malaise, which is general weakness, and then a lot of times you'll have a cough, but it's non-productive. And then you may even have a low-grade fever and chills. So it kind of just sounds like the flu, but it's not. And then also, if it's not caused by that bacteria, it can also be caused by Legionella species. So this is specifically, the way that you get this one is transmission between water droplets, so meaning that you inhaled it. It's kind of just a side note. Okay, so now for hospital acquired. So this means that you got it during your stay at a healthcare facility, whether it be actually at the hospital, in the ER, or in a long-term rehab facility, whatever it may be, any healthcare facility. So the most common cause of healthcare acquired pneumonia is P. aeruginosa. So P. aeruginosa, he normally doesn't cause any issues, but he is opportunistic, meaning that if he sees that you are immune weak at the moment, he will take the opportunity and actually cause a disease. So he is gram negative. And then also with P. aeruginosa, as we know, there are a plethora of virulence factors that come with him. that make them very, very difficult to treat. And the major contributor to pneumonia and the mortality in patients with cystic fibrosis. So you will see this in CF patients because of the fact that they are so immunocompromised. Also, they have issues with their lungs and actually clearing out that mucus. So with the fact that they have an issue clearing out that mucus, P. aeruginosa will take advantage of that and start colonizing. And a lot of times that'll happen during their stay at a hospital. So definitely keep that in mind. So cystic fibrosis is an example of a immune compromising condition that can increase the rate of which a healthcare acquired pneumonia may occur. Okay, so I believe we're just going to talk about tuberculosis and then we are done. So tuberculosis, so this is generally caused by that MFAST bacterium, Microbacterium tuberculosis. So this bacteria, what it does is that it does spread from person to person. There is no known reservoir for tuberculosis. What will happen is that you will come in contact with the aerosol droplets and then you will inhale, and then that is how you become infected. Once the bacteria has entered the host, what will happen is that it will start being phagocytized by macrophages, but that's actually not a good thing because it can actually survive within phagolysosomes. So what it'll do is that it'll slightly alter phagolysosomes and it will just live in there. So with tuberculosis, it will, over time, as it continues to colonize and cause disease, you may get something called lesions within your lungs. So this is where you can actually see, so if you were to ever take an x-ray of a tuberculosis patient, you will actually see like these gray shadows. So those are the Gone complexes. And the reason why that happens is because granulomas are formed in order to contain the infection. Okay, so what happens is that tuberculosis, it generally, so let me start over. So tuberculosis generally is actually cleared, but whenever it's not, it will incubate for an extended period of time, and then if that is the case, then it becomes latent tuberculosis. So that is where you can get the two phases of the disease, the primary and secondary. So primary characteristics of the disease is where you have a productive cough. So a lot of times you have like sputum, you have fever, night sweats, and maybe even some weight loss. So this is where a patient is considered active TB and they are contagious. Now, secondary, this is where it can become reactivated, and this is where it can be associated with more severe symptoms, so like the blood sputum, also night sweats, fever, weight loss. So it's kind of just like the primary, but this is where you actually have blood coming out. And with that, a lot of times that means that it may disseminate into tissues, and unfortunately, tuberculosis can be deadly. So if you've ever seen the movie Moulin Rouge, spoiler alert, guys, fair warning, the main character that Nicole Kidman is playing, she actually has tuberculosis. So just if you do ever want to see clinical symptoms, they actually kind of did it fairly decently, where the night sweats, the coughing and everything. So you can actually die from tuberculosis, but it's not as common here stateside. Okay, so with that will wrap up our lecture. So we talked about the anatomy and physiology of our respiratory tract, the upper and the lower. We also talked about the ear canals. We talked about different infection types, so including the symptoms and then possible causes and then treatments, if any. We also did talk more in detail about angenic shifting and drifting, so definitely take a look at that Khan Academy video, guys. It's really good. So come test time, I would want you to be able to tell me, like, if I gave you a scenario of saying, like, your patient has XYZ, I would want you to be able to tell me what do you think it is or who's the possible causative agent. So definitely keep that in mind whenever we're going through this, okay, guys? So if you have any questions, definitely don't hesitate to contact me. If not, then I will just see y'all in class.